Welcome. Hi, I'm Christina Booth. I'm one of our nurse practitioners here at the Center for Colorectal and Pelvic Reconstruction at Nationwide Children's Hospital. I am joined today by Dr. Jerry Hewitt, our Chief of Pediatric and Adolescent Gynecology here at Nationwide Children's Hospital, and Dr. Kate McCracken, one of our attending pediatric and adolescent gynecologists here at Nationwide Children's Hospital. Today, we're going to be talking about all things gynecology. So Dr. Hewitt, Dr. McCracken, welcome. Thank you for joining us.
Thank you.
Thank you.
Dr. Hewitt, will you tell us, we often get asked, why would a patient see a pediatric adolescent gynecologist in their visit with our Center for Colorectal and Pelvic Reconstruction?
Right. So that is a very interesting question. And in fact, all of us inside of CCPR recognize that we like our female patients to see gynecology. But that's a question I even get asked by other providers inside Nationwide Children's Hospital. What is gynecology doing inside of CCPR? And in fact, next week I'm giving a grand rounds for the whole institution explaining why we are living inside of CCPR. So when I think about what our role is, I think about it as sort of two areas. One area is a lot of families live in communities they don't have an opportunity to address their child's young girls' reproductive health care needs. So regardless of a diagnosis, we're here and available when you come to Nationwide Children's Hospital to have contact with a pediatric gynecologist for any reproductive health care related need. Specifically, some of the girls with diagnoses that they're specifically coming to CCPR for have overlap with gynecology. So sometimes if girls are having pain or they have other anomalies, they have questions about what contraceptive methods might be appropriate down the road in terms of is any of the medications they're on impacting fertility or a safe pregnancy. Those things can all be questions that families have had. How does this diagnosis impact their reproductive health? What is their anatomy? What does this mean long term? So straightforward reproductive health care questions or questions specifically associated with their diagnosis that they're coming to CCPR for. But we're here embedded inside the program. Some families ask to see us. Some families we ask to see them to educate them. But we're here and available.
Wonderful. And Dr. McCracken, what are some of the unique challenges that you see in females with a history of anal rectal malformation?
So in girls who've been diagnosed with an ARM, they typically fall into three categories of anomalies: of rectal vestibular or rectal perineal malformation or cloacal malformation. And each of those has its own unique challenges and their own unique considerations when we're talking about their reproductive health. So some of that relates to anatomy, which is important at the time of diagnosis and the time of surgical repair. Sometimes it is not necessarily on the forefront of the initial diagnosis and repair, but has longer implications at the time of puberty or at the time of family planning in the future. And so when we meet with a family and we go over their child's unique diagnosis and conditions and associated conditions, as Dr. Hewitt mentioned, we put that all together and make an assessment on how this impacts their reproductive health. And I think one thing that we often focus on and talk to families about is that reproductive health care is a longitudinal assessment and a longitudinal sort of plan of care that we may pop up as gynecologists initially and then go to the back burner for several years, even a decade, until they're pubertal again. But having a gynecologist as part of the team is helpful so that we can make sure those reproductive health care needs are not missed.
Right. And I think to add to that, when I walk in the door for a first time with a family that's coming to CCPR, oftentimes they have a kind of a laundry list of questions and they have a lot of emotion around the diagnosis. And perhaps they've seen a pediatric surgeon or they've seen a pediatric urologist. But oftentimes they have lots of very specific questions. And usually, like Dr. McCracken mentioned, they want to know anatomy. Explain our anatomy. It hasn't really all fit together and they've had a hard time understanding it. Maybe some of the imaging studies have suggested some things that we know aren't true, like the absence of not seeing ovaries. So confirming the diagnosis, explaining to them what their anatomy is, and then talking long term about what that anatomy is going to mean for them over the course of their life. And kind of our goals are to get the best procedure for them for the best long-term reproductive outcome and make it so that they minimize the number of repeat procedures they need to have done and sort of set them up both anatomically and as well as education expectations for what this will mean for them over the course of their lifetime.
There are a lot of fears and a lot of emotion, like Dr. Hewitt mentioned. And so part of our job is to counsel and to help, provide education and information so that they feel like well-informed parents, so they can be advocates for their daughter as they grow. And they can help explain to their daughter, what does their anatomy mean and what does this mean for your future? It's always astounding. Well, not really astounding anymore, but it was astounding at first when we, were starting with this team, that so many parents were really concerned about their daughter's ability to parent themselves when they were older at that initial visit with us. When they're a baby, that is on the forefront of their mind. And while that may not be on the forefront of other providers' mind, as a reproductive healthcare provider, we understand the importance of that question.
Right. I think the question of, I've had parents with a 4 or 6 month old baby on their lap ask me with tears in their eyes, will someone love her? Will she be able to have an intimate sexual relationship? Will she ever be able to parent? So we spend a lot of time talking about what her anatomy means, what patients with this anatomy experience in terms of sexuality and sexual functioning, and then ways to make a family.
Right.
And those are things we feel very comfortable addressing. And oftentimes we sort of go in with some anticipatory guidance and some anticipatory counseling around those issues. And that's kind of our bread and butter, and it's what we have passion around. And then we feel very comfortable talking about those things. And we have good news about those things.
Right.
And oftentimes families just haven't had the opportunity to talk about those things, or
they may not know the questions to ask.
Right. Or kind of the space of how you get those questions answered. But, moms of 6 month old babies are asking us, is someone going to love her? Will she ever be sexually intimate in a loving sexual relationship? Do people with this diagnosis, are they able to have sex? Are they able to create a family? And, we have good news about that.
Great. And tell me, what's the typical evaluation look like for this patient population? What do you guys typically recommend, or what do you do during those visits?
So I think initially when we meet the family, we're often part of the team that will be present for an exam under anesthesia when they're evaluated. And that really is helping us define the anatomy. So when we think about the reproductive system, we think about sort of external genitalia, external anatomy, the lower vaginal tract, meaning the vagina, presence of a vagina, up to the level of the cervix or cervices, which is the bottom part of the uterus. And so when we're present for that initial exam under anesthesia, we're looking at all of that anatomy. We're also taking into account any sort of imaging that the patient may have had, and what does that tell us about the internal reproductive structures, which we may or may not have all the answers at the initial diagnosis. And so the initial evaluation is putting together that exam under anesthesia, figuring out as much as we can about the anatomy using the exam and imaging, and then being present, if needed, at that initial repair to help further understand the anatomy and, like Dr. Hewitt previously mentioned, optimize the repair to optimize their health in the long run. So that's sort of the initial evaluation. And then we, after the repair, we may not be seeing the patient, monthly or weekly. But then at the time of puberty is when gynecology comes to the forefront again.
Yeah, so sometimes initially it's, like Kate mentioned, examination under anesthesia, vaginoscopy, and sometimes it's something as simple as examining them in the office.
Exactly.
Sometimes when they're going to do a diaper change, we just need to kind of take a peek and see how things look, and if things look reassuring, that might be enough with specific diagnosis that we can sort of back up the bus and we're here if you need you, we need to see you at puberty.
Right.
Other times we need to be more involved with that initial evaluation than just an office exam.
And in some patients, they may not be an infant when they present to our center. And so putting together data from previous exams, previous procedures, previous imaging, putting that in the context of a physical exam or an exam under anesthesia with vaginoscopy, sort of putting the puzzle pieces together to give what we think is our best guess at their anatomy at this time, or what procedures they may have had or may need from a gynecology standpoint. Because not every patient presents to us as a baby.
And I also think when you were mentioning that, I was thinking the word synthesizing, right? Pulling all these things together to know, to try to understand what the patient's needs might be in terms of reproductive health. Right. And then to know what, based on what we see, based on the synthesis of everything that's happened, based on what the patients and the family's needs are, what's the best way forward? It's not always surgery.
Right.
You know, we might be talking about pelvic floor physical therapy. We might be talking about vaginal dilation, but sort of synthesizing a plan and being able to pull all these things together with multidisciplinary discussion
Right.
and with an understanding of these diagnoses that, you know, some gynecologists that don't work with these diagnoses a lot might not be as familiar with, and be able to coordinate, synthesize a plan moving forward.
I'm glad you said coordinate, because I think that that's really important. And one of the strengths of our center is that we have the multidisciplinary approach all under sort of one umbrella, where we're not operating in silos. We're operating with each other and putting our thinking caps on together when we do need to make decisions, whether or not we need to surgically intervene, or if we do, who needs to be involved in those procedures. You know, so I think it's really great that we have our colorectal surgeons, our urologists, our social workers, our psychiatric partners, our GI partners, so that together we can sort of formulate the best plan for the patient using a shared decision-making model.
Yeah, and
with
I
the
would say
family.
too, we know from studies that we've done that we can spare children anesthesia.
Right.
From working together, we can do procedures together at the same time and minimize anesthesia exposure. And then also we know that doing, let's say, a colorectal procedure and a gynecologic procedure together, integrated, does not increase any risk of adverse events.
Exactly.
So we know that working together can decrease the amount of anesthesia exposures, and we know there's no harm in doing our procedures jointly.
Wonderful. Very helpful information. Now, Dr. Hewitt, we often get asked about patients and what they should expect during puberty, and also what information we know about sexuality in girls with history of anal rectal malformation. Can you highlight, you'd mentioned these things earlier, can you maybe highlight a little bit more about that?
Sure. So I'll speak of puberty. Maybe I'll ask Kate to speak about sexuality.
Sure. Okay.
But in terms of puberty, lots of times patients will come to see us and they'll have had imaging done where the ovaries have not been seen. So we have a lot of families asking us, you know, there's so many other problems she has. What's puberty going to be? Well, the good news is we think if girls are healthy and they have good gut absorption, ovaries are present, and they should have a normally timed and tempoed puberty, meaning it should start when it's supposed to start and it should progress in a normal manner. Now, if kids have, you know, limb abnormalities and less mobile and they're heavier in terms of their weight, their puberty might be a little bit earlier. Or if they have malnutrition, their puberty might be a little bit later. But if they're healthy, they have good diet, their normal weight, good gut absorption, puberty should be at the normal time. And we're really interested in puberty because we know as many as a third of girls with anorectal malformations might have an abnormality in their uterine structure. And we worry about that in terms of when menses happens, we want to make sure there's a conduit or a way out for the menses, the menstrual blood, what we call menstrual egress. So we're very interested in families' pubertal process or their experience. We like girls to let us know when puberty starts with the onset of breast development. That's going to trigger us to think about how great a risk is this patient is of having menstrual obstruction. And it may cause us to order some imaging studies, like a transabdominal ultrasound, to look at the structure of the uterus. Again, it's bigger, it's grown, it's had the estrogen stimulation through puberty, to make sure we understand the anatomy. And then we want to know when they have their periods and how much pain they're having, to make sure, again, watching very closely for obstruction.
And I think in regards to sexuality, it is good news. And, you know, often it can be uncomfortable maybe for the parents to ask that question about sexuality. So sometimes we preemptively just talk about it. These are questions you may want to ask, or we may want to talk to your daughter. I think we're very comfortable as gynecologists navigating that dynamic with parents and families and caregivers and the patient, and also separating them when necessary and talking, you know, individually. Sexuality is multifactorial, it's multidimensional. And so while we sometimes talk about anatomy a lot, we know that sexuality is not just about anatomy, which is really important to discuss. We talk to our patients about body image. We talk about continence. We talk about how the presence of scars or stomas may impact their body image and sexuality. And the good news is that patients with anal rectal malformations and other diagnoses that we may see are sexual beings. They have intimate relationships with people, and they have satisfying intimate relationships. So I think that's really important. And that's, you know, we sort of talk about girl power and empowering people to, to be sexual beings and safe sexual beings. And part of that sexuality discussion talks about contraception and safe sexual practices, which again is bread and butter gynecology for us. And so depending on a patient's uterine structure, that may impact the ability to use certain types of contraception. Other medical comorbidities, their renal status, their kidney status, their mobility may impact, sexual activity and contraception. And it also affects menstruation, which I think we talk about too as gynecologists, not just the ability to have menstrual egress, but to manage menses. So around the time of puberty, we talk too about how are periods going? Are you able to manage flow? Are you able to manage pain? If you have, mobility limitations, how can we help you with menstrual management and sexuality? So for us, that's part of what we do every day in our gynecology practice. And I think it's a big part of what we do within CCPR.
And the two things I always tell families is, we know from surveys of patients with ARMs that they are sexually intimate.
Mm-hmm.
On average, they just initiate sexual activity a little bit later.
Right.
So parents like to hear that. That's good news for most of them,
Sure.
that their children will be sexual beings and they'll have satisfying sexual, but
Right.
they may start sexual experimentation either alone or with a partner a little bit later. We think it's about 2 years later than the typical population.
Mm-hmm.
So one thing we really want to assess is the size of their vaginal opening, because
Right.
we want them to be, if they are interested, to be able to use tampons. And then later for penetrative sexual activity, that's vaginal sexual activity, that's something they want to do. But we like to take a look and assess that because we don't want any experiences to be traumatic.
Exactly.
Whether it's attempting to use a tampon or attempting any sort of vaginal penetrative sexual activity. So that's something too we talk to families about.
Mm-hmm.
Like we just want to take a look and make sure everything looks good. And improving things may not mean surgery. It
Right.
may mean pelvic floor physical therapy or vaginal dilation.
Mm-hmm. Mm-hmm.
So, Dr. McCracken, what is the role of the pediatric gynecologist when a patient with the diagnosis of anal rectal malformation becomes pregnant?
Right. So that's a great question. We get that. We answer that a lot. So one of our biggest roles is to empower the patient with the appropriate information that they can transition their care from a pediatric provider or pediatric center to an adult center that could provide them with ongoing reproductive health care. So understanding their anatomy, understanding the procedures they've had performed, understanding what they need to do to optimize their medical health before they have a pregnancy. A planned pregnancy is sort of the ideal, so that we can make sure that a patient is medically optimized, meaning is their kidney health okay? Has anyone assessed their cardiac health if they need to? And so talking to the patient about all of those things they should think about, as they're deciding to start a family. So timed pregnancies, planned pregnancies, medical optimization, discussing the importance of maybe needing to meet with a high-risk obstetrician when they do want to get pregnant or are pregnant, so that they can talk about their other medical conditions. And then we often get asked about the mode of delivery or the route of delivery, vaginal delivery versus cesarean section. So talking to the patient about their anatomy and their current level of continence, and doing shared decision making with the patient about what might be the most appropriate mode of delivery when you are pregnant. The other obstetric consideration that we talk about is the role of anesthesia during labor and delivery, and maybe the need to meet with an anesthesiologist before you're actually in labor to make a plan, because often our patients have associated spinal anomalies or malformations that may impact their ability to have particular types of anesthesia during labor and delivery. And then I often talk to patients about, delivery and mode of delivery, not only meaning, do I need to have a C-section or can I have a vaginal delivery, but who may need to be there as part of a planned procedure if I have a cesarean section. So understanding sort of a roadmap of their abdomen and prior procedures. Do they have stomas? Do they have conduits? Do they have other anatomical differences that may impact the type of skin incision that they have, the type of uterine incision, or the presence of other surgical services when they go to deliver, such as urology or colorectal surgeons. And empowering the patient to take that information to an adult provider who may not be as familiar as others with women who've had anal rectal malformations and repairs of those malformations.
Wonderful. Well, thank you, Dr. Hewitt. Thank you, Dr. McCracken.
You're welcome.
Thank you for joining us here today. If you'd like more information about our Center for Colorectal and Pelvic Reconstruction at Nationwide Children's Hospital, please visit our website at www.nationwidechildrens.org/ccpr. Thank you.